Welcome to DentalXP.com. I'm Dr. Maurice Salama, and today we're going to take you through a presentation or case report of a dentist's first implant case. Classically, we have a lot of students that come to the Dental XP Training Center or are part of our hands-on or live patient curriculums, and very often they have very limited implant experience. This was a restorative dentist's first implant endeavor in the surgical arena. She's had experience with the restorative aspects of implant dentistry, but not the surgical aspects. And typically what we like to do is get them in a comfort zone. This is an excellent situation, this clinical case with the first bicuspid suffering from internal root resorption. Endodontic consultation revealed that this patient's tooth had a very limited long-term prognosis, and the endodontist had suggested that it needs to be removed and a dental implant inserted. What we're going to take you through today is with a beginner in implant surgery, dealing with extraction, site management, the removal of tooth, the augmentation, socket grafting procedure, a staged approach, not an immediate approach, to allow the grafted area to completely heal, then re-entering that area and placement of a tapered threaded dental implant into the healed site. This is a traditional conservative approach to management in this area. I think it's an excellent way to start in your endeavors with implant dentistry, and I hope that you will enjoy the video presentation. So here you can see the placement of a mini elevator into the sulcus. We want to completely cut the junctional epithelium and connective tissue fibers completely 360 degrees around the damaged tooth. It's very important that this is done before any subluxation or placement of elevators. The dual extractors are going to be utilized to initiate subluxation, and then we're going to use piezoelectric technology and periotome tips entering into the periodontal ligament space. This is a very important aspect of new technologies that assist us in atraumatic extraction. Very important that you get trained along this facet because there's a lot of different tools available. It's important not to keep the tip in one spot for very long. You can see constant movement and irrigation during the process of using the piezoelectric periotome tips. Now, after entering the periodontal ligament with the periotome tips on the piezoelectric device, we then subluxate with the extractors and then very gently with the forceps, rotational movement only, to completely extract the first bicuspid without any damage to the surrounding socket walls, in particular and most importantly the labial plate. Here you can see the tooth being evaluated for any fractures of remaining parts of the root. This is very important that we don't leave behind any root fragments. We're then going to go ahead and utilize serrated curettes to completely remove any granulomatous tissues or soft tissues from the socket walls, and also to evaluate the type of socket environment we're dealing with, and in this case it was a type 1 with all 4 walls remaining. We're now going to place, typically in extraction sites, a mixture of plasma-rich growth factor, PRGF, mixed with mineralized irradiated bone, in this case Mineros. And we're going to do this and then place a fibrin or PRGF plug as a seal to the graft. And here you can see us placing it in there with the bird beak instrument, very lightly condensed. And this kind of mineralized irradiated bone with PRGF is a medium turnover product because it has cancellous and cortical bone chips. And here you can see Dr. Wendy very excited with her first implant being placed. This is just my evaluation of the socket. And here you can see at approximately 4 months how well this socket has healed, so that now she can re-enter at approximately 4 months in an intact, pristine, staged approach, healed environment to place her first dental implant. Sulcular incision is done from the mesial of the molar to the distal of the canine, and full thickness flap reflection all the way to the buccal aspect so that we can envision and evaluate the healed site, specifically the buccal wall and any potential concavity. And this is typical of what we see with mineralized irradiated bone because of the cancellous and cortical component of that graft. We see excellent healing, very difficult to detect what is the grafted bone, the newly healed bone, and the surrounding intact bone. Very nice that you can see how well that buccal plate has been maintained, and now Dr. Wendy on her first implant drilling to the depth markings. This is the Hyacinth implant system. This is the ET3, the tapered threaded system with a corkscrew thread pitch. And she's going down to the stops, which is very important with your first implants. Having a stop on the drills allows you to feel more comfortable so that you're not going to place the implant too deep. So the vertical stops, so important. Evaluating the direction indicators to make sure that you're coming out through the central fossa for good biomechanical load, as well as for a screw-retained option for your prosthesis. The dedicated final drill, again, with the laser marking and the depth stop that allows us to control the vertical depth of drilling. And here from the vertical axis, you can see how wonderfully she's done. Very nice 360-degree placement of the implant with at least 2 millimeters of bone beyond the buccal surface of the implant. The ET3, again, a tapered threaded implant is going to be inserted into this healed site. For the first implant, it's very nice that you have the ability to hand ratchet if you'd like. I like to do it with a driver so the beginners can get a comfortable feel for the bone and how tight it is. Or you, of course, can use a handpiece adapter. And here you can see us maintaining and allowing that implant to self-tap into the well-prepared osteotomy site. The depth of placement, I always tell most of the beginners posteriorly, about 2 millimeters below the future gingival margin of your restoration, or if you use the cemento-enamel junction of the adjacent teeth, about 2 millimeters on average, not less than 1, and not more than 3 millimeters below the adjacent cemento-enamel junctions of the adjacent natural dentition. Here you can see very well the top of the implant being placed exactly where we like it. It can be ratcheted down maybe another ½ millimeter or millimeter before final closure. Evaluating that now from an occlusal perspective, we have an abundance of keratinized gingiva here. So rather than do this as a one-stage approach for beginners, I like to go back to the traditional staged approach of completely submerging the implant during the osseointegration phase. I think it's safer. And again, early on with newcomers to implant dentistry, I think it's important that they start in the posterior region doing these cases classically. Extraction, simple incisions, staged approaches, letting the extraction site heal, not placing implants immediately, but allowing the bone to fill. And then when placing the implants, simple incisions, placement of the implant into healed, intact sites, and then doing this as well in a staged approach. And here you can see just 2 simple vicral sutures interrupted is all that was necessary to close the flap. No further augmentation was necessary. You can see we have a very good buccal lingual width to the ridge. Here is the Hyacinth ET3 implant in position. You can see how well the vertical stops were maintained to get the ideal depth control for this restorative dentist's first implant. I'd like to thank you all for joining us on this, what would I say, my first implant series. And this is what safe education is all about, being mentored, going to courses, and being able to not only do the didactic portion, but obviously eventually the hands-on portions on synthetic jaws, pig jaws, cadavers, and then eventually having it over the shoulder on your own patients. I'd like to thank you once again for joining us here at Dental XP. I'm Dr. Maurice Salama.